Groups of physicians. So say an example, okay?
Yes.
For an example, if I refer my patient to another physician for a procedure or a surgical, a surgery, or if they need to see a specialist about a specific issue, as a family physician, you rely on coordinated care with other physicians, other healthcare providers, and establishing that trust or helping the patient establish that trust sometimes can be difficult. Because they haven't met the doctor before. Sometimes the questions that are asked are, is this person an African American? Is this person a man? Is this a woman? Is this a young person? Is this an old person? Do you know this person? Would you have your mom see this person? And that nobody's ever asked me all those questions at once, but usually patients will ask because they're suspicious, they're worried, and I can tell where that's coming from. And it's not always rational, that's for sure. But I understand it, and as a family doc, that's what you're there for, to help with coordinating care. So from the patient's perspective, it usually comes up when I'm referring to another physician. With me in particular, I think too, when I take care of patients who are not my own, because we are teams and we take care of each other's patients when another doctor is not there, it comes up too. So a patient I've never met before, they have no idea. Typically they'll ask, well, where'd you go to school? Oh, you went to Georgetown. That's great. And sometimes that helps, but being a young person, being a minority, sometimes I find that changes what the trust perspective is when I've met someone for the first time.
That's one of the questions I had for you. How does age factor into this element of trust?
I think it really does for me in particular. I mean, I'm very blessed to be able to look young, but when I first meet patients, especially elderly patients or anyone actually, it doesn't really matter how old they are, there is some skepticism about whether I'm old enough, and people actually ask, are you old enough to be a doctor? You look like you're 18 years old, which is really ridiculous because I don't look like I'm 18, but I can't tell you how many times I've heard that. I heard that a lot as a medical student when I was here at Georgetown, and that was 1999. That's a long time ago, But for me, yes, I still get it. I still have that when I meet a patient for the first time. I walk into a room and I'm wearing my long white coat as an attending, and I'm walking in with a student who maybe looks a little older than I do, and sometimes the patient refers to the student as the physician. So it happens sometimes.
And how do you deal with it?
I mean, I because I'm used to it, I don't really react to it. I just introduce myself, who I am. Part of your role in a healthcare team is to introduce yourself as the leader of the team. And so I'll say I'm the doctor in charge of the team today if I'm on the inpatient service going into somebody's hospital room. If I'm in the clinical setting, I'll say, if I haven't met the patient, most of my patients know me really well, so they're not seeing me for the first time. But if I'm seeing someone I never met, I'll say, I'm Dr. Roett. I'm the doctor in charge of this facility. This is a student working with me today. Do you mind if the student comes in? So that sets the precedent for, who I am and why I'm there and what my role is. But I gotta say, a lot of times the response is, well, you look too young to do this, and why should I trust you? Or, and that goes really far, but you have no idea. Do you have any kids? You don't have a teenager. People are, that trust issue can go in 20,000 different directions. And so it's not always obvious about where it's coming from. When it comes to treatment, when I have to give somebody an injection or a shot, those types of questions come up again, what is this for? What is this going to do for me? Or if somebody has to come back and get a shot and I'm not there, are they going to do it with a different doctor? Those questions come up. So you have to be very cognizant of it and understand where the patient is coming from. And that's why cultural competency has such a big part of education now, so that as physicians we can be prepared.
And how do you use cultural competency to establish that trust with patients of different ethnicities?
I think, I mean, it's not that overt. I think understanding where someone comes from, where they live, what's important to them, using motivational interviewing, using your relationship and rapport with the patient to talk about their life outside of what medications they're taking and what was their blood sugar yesterday. Sometimes it's a good idea to spend that time getting to know their family, knowing how many kids they have, and to me, that's the beginning of the relationship. And every culture is different. Some people are very private and not wanting to talk about their family relationships, and some people are very open about that and really excited to talk about their community or their family or their church. And so you won't know that until you start talking to someone. So to me, the best thing is to not try to judge or put people in categories when I'm seeing patients. Everybody's an individual, no matter what culture they happen to represent, and you can't make assumptions about somebody who's African American must be from this neighborhood, or somebody who's Hispanic must be from this. You really couldn't. You have to start from scratch and not think about that at all. And I think it's easier for me because it's been a long time of doing it, and I see multiple ethnicities in my practice. It may be more difficult if I wasn't. I'm not sure, but I've been doing that since medical school, so it's never been a barrier or a problem for me. But getting to know someone's culture, someone's background, someone's intimate thoughts and feelings helps you to establish trust. Mm-hmm.
Great, thank you.
Yeah, you're welcome.
So we were talking about the historical aspect
Mm-hmm.
of mistrust in a lot of communities, the African American community, Latino communities, because of past medical abuse. How do you deal with that with patients?
Well, patients don't really bring it up, I would say. The two major issues that I think most patients are aware of in this area because of the proximity would be Henrietta Lacks. And then, of course, everybody is aware somewhat of the Tuskegee experiments. And so I would say those are the only two real issues that have come up. There are other socioeconomic, psychosocial issues that have happened within, particularly the Black community, that come up in conversations, like the introduction of crack cocaine into neighborhoods. That's come up with my patients. But the Henrietta Lacks story is complex. There's so many layers to that, and there's not a great understanding of how much her cells actually contributed to so much industry today. There's more books on her now and her story. Have you read it?
Yes.
Fascinating story about her, but most of my patients haven't read it. They just know. They know of her name, they know of the situation, they know that her family was taken advantage of, that they didn't, that somebody profited off of her suffering. And talking about it, I have to say, it doesn't come up in regular conversation. It has come up sometimes when I've talked to people who have a cervical cancer diagnosis, or uterine cancer diagnosis even, which is not what she had. And some people are familiar with the fact that was what Henrietta Lacks had, and they're wondering, what are we doing with this colposcopy? Because that's the procedure that you do to do a biopsy of somebody's cervix. And it's literally, you have an abnormal pap smear, you're doing a colposcopy, you're trying to figure out, is there something worse happening? But it's a very invasive thing for a woman to go through to do a colposcopy. So I think there's always worry, there's anxiety, and sometimes there's a discussion about that, because people understood that she suffered. And, we're really far away from that today, and that, it's a pretty rare chance of diagnosing cervical cancer because of screening and all the monitoring that we do. So I haven't got that far of someone who has cervical cancer and who's thinking about themselves in her shoes. I really haven't had that. I've seen a few cervical cancer cases, but really none that I was meeting the patient for the first time and just diagnosing them. Most of my patients I knew already.
Right. Another topic would be what initiatives are taking place in family medicine to establish trust? I've heard of community health workers, navigators.
Yeah, that's very popular. So in the patient-centered medical home, which is a family medicine, pediatric, internal medicine, typically primary care practice initiative, family docs have really taken it, really seriously to implement at a higher percentage in their practices, and that's coordinated care. And the role of a community health worker, navigator, we call our role a community health educator in our practice, is to bridge the gap. And sometimes that's not just about cultural competency or trust. Sometimes that's about health literacy and being able to understand the processes that need to happen to get a test or get a result or get a procedure done. So that navigator is typically somebody from the community, somebody who's more relatable than the physician theoretically, and who spends more time. I think that's the key, is the time and the understanding And a physician who has a 15-minute visit is not spending an hour with a patient typically. And, we balance our time, and there are plenty of patients that I spend an hour with. But it's priceless to know that there's another person that's going to talk to your patient in between visits. When they come in, they have this familiar person who could sit in with the visit, who could talk to them afterwards to make sure that they're understanding of what's happening, and work with the doctor to take care of the patient. And some patients want the navigator or health educator to go with them to their other appointments. And some places do that too. And they do home visits, they do all kinds of things. So I would say family docs take advantage of that. Some of us do the same things, go to people's homes, go with our patients to appointments, go to nursing homes, go to different settings. But having a community health worker is almost like an extension of that coordinated care in your office. And honestly, patients, when our community health educator, I think, got a larger job and moved on somewhere else because she just got her graduate degree, everybody was so disappointed. The patients were so sad. And then we hired someone else, and now they're bonded with her. So it's one of those things where it's a critical person to have, and it's not really about that individual person. It's about the role and understanding that there's somebody there that I can ask questions anytime.
That's great. Seeing that you're in family medicine, I feel like you have a greater advantage in being able to develop that trust because it's long term.
Yeah.
Would you agree with that?
Oh yeah, for sure. I mean, just the nature of being there when somebody's pregnant, when they have their baby, watching their child grow up. I think that's not really different than a surgeon who's seeing somebody for one surgical procedure could establish that relationship. It's just the nature of that relationship is just for that procedure. So the surgeon might never see that person again. But by the same token, I know surgeons who have their patients come and follow up every year, and they know them really well, and they have a good relationship. But as a family doc, I tend to be the person who took care of the baby, the mom, the sister, the brother, the neighbor, and that's a unique relationship. I can't talk about that when a patient comes in. I can't say I just saw your sister yesterday, because that would be a HIPAA violation. But I could just say hello to your sister. It means a lot for patients to think that you remember who their family members are. Or I could say, oh, I remember your mom. Could you say hello to her? Tell her she's supposed to come in. I think that helps. And then oftentimes families come in together. So to me, that's a great visit. Not a great visit from the physician point of view, because it's hard to get everything done when the whole family's there. But it's unbelievably fulfilling to see the whole family. And when 3 kids are in the room, it could be chaotic, but it's fun. You're getting to see mom interact or dad interact with the kids and how they interact with each other. And you wouldn't see that ordinarily if I was just the doctor for one child or for mom. I might not have a chance to see the family.
Thank you. And the last question to wrap this up. So at the end of the presentation, I wanted to give some, I wanted to show a piece of this video and you providing advice for the GEM students as to how they should behave when we finally go and meet patients.
How they should behave.
Or
That's
how
a
do you establish that trust or keys to establish?
Well, you know what? I think being yourself is very important. If you're trying to, put on a persona to speak with your patients, most patients will see through that. And so being yourself, being as relaxed and calm as you possibly could be as well, because, we could be nervous. We haven't met this person before. Somebody's evaluating, watching me. Trying to understand where to find that calm place, because the patient really appreciates it, and trying to not just ask questions about the history and physical and the things that are in your list of to-dos for the class that you're taking or whatever it is that you're evaluating the patient for, but asking about how they're doing, and did your mom come to visit you again today, or, if there's a family member there, to engage them as well. And try to connect with the patient personally. There's no one formula for that, but you know how to interact with other people. You know what you see when somebody's eyes light up when you ask them a particular question. You could ask them more about that, or you could say, would you be willing to talk to me some more about that if I come back later? And patients really appreciate it. So think about what's that one thing that you could ask your patient today that's different from the list of to-dos on the H&P. It could be anything. There's no one formula, but if you could think about that one thing, you could connect with your patient really well. It could be, you look a little bit sad today. What's happening? Or how was church on Sunday? And you couldn't ask that unless the patient had said they went to church. But you'll be able to judge. You guys have tremendous training. You've had so many interactions with people professionally already, and personally, you know how people respond to you. So use your own judgment, be yourself, project calm, and think about that one thing you could say to connect with somebody.
Thank you.